Good morning, everybody. Thank you very much, Sanjay, Chetan, for the kind invitation. It's nice to be here again. Mr. Chairman, thank you for the nice words for introduction. I hope I deserve them. So this is where I work. It's in Abu Dhabi, United Arab Emirates, and it's a tertiary hospital. We do everything almost. So which one is... I'm sorry. I'm using the wrong one. I have no financial disclosures. This is my clinical disclosure. I do mostly revisions, then sleeves, OEGBs, and bypasses. Right, so what about synchronous laparoscopic cholecystectomy along with bariatric surgery? I mean, there's a big talk about it for a long time, and I just wanted to make sure that, to clarify whether it's evidence-based or dogmatic. And, there's a big difference between the two. But it all comes to one thing, to Hippocrates, the Hippocratic oath. So many ways of reading it, but basically it's primum non nocere, which first do no harm, and then if you secure that, you go to benefit. And this is probably, this is basically what we all do about. So let's talk about the evidence. And the first thing is gallstones on their own. Forget about bariatric surgery. Watch and wait or intervene. Is there a difference? And that's a study that proved that most patients with asymptomatic gallstones remain symptom-free, while about 20% develop gallstone-related symptoms. So again, I'll go into a breakdown of that. So 20% develop the symptoms, but not 20% require surgery. And those who eventually require surgery is around 8%. So while this paper talks about the risk factors for symptomatic gallstone disease and gallstone formation after bariatric surgery, and it's a good number of patients, almost 1,000 patients, only 8% of them develop symptomatic gallstones within 2 years. And even those patients, the outcome was improved, the statins and UDCA prophylaxis reduced the risk of development. And the story goes on. I'm just, of course, focusing on the big studies and meta-analyses and more recent studies than the old ones. And here, this is a study about the risk and prophylactic management of gallstone disease in bariatric surgery. It's a systemic review, and from Portugal, and they found that the risk of de novo post-bariatric gallstone disease was not higher than the general 20% that we just talked about in the first paper. It's around 20.7%. And again, symptomatic gallstone disease was 8.2% versus the 8% of the general population. So more or less it's roughly the same, percentage-wise. And the odds of major postoperative complications were higher in patients who had concomitant bariatric surgery and cholecystectomy, and that was a finding, and that's why the argument was it's still arguable, that's 2023, it's still arguable that prophylactic cholecystectomy is a fitting approach for patients with preoperative cholelithiasis. The story goes on. I'll give more evidence about that. This is a prospective study of conservative management of asymptomatic preoperative and postoperative gallbladder disease in bariatric surgery from Mexico. And every patient submitted to bariatric surgery was included from 212 to 214, and it was assessed by ultrasound before and up to 12 months after surgery. And they found that conservative management, they conducted actually conservative management for patients with asymptomatic disease, whether preoperative or de novo postoperative. Their conclusion was that conservative management of asymptomatic gallbladder disease in candidates for bariatric surgery was safe and can be offered to every patient. And there's a low percentage of patients who required further cholecystectomy within 1 year, which is 3.4%. Again, if you compare that to the general population, it's still a very low percentage. So how effective it is to follow conservative management versus laparoscopic cholecystectomy in prevention of recurrent symptoms and complications in uncomplicated gallbladder stones. So this is a very famous Seagull trial. It's a pragmatic, multi-center, randomized controlled trial. And they found that in the short term, less than 18 months, conservative management as an alternative to surgery may be effective and cost-effective for patients with uncomplicated gallstone disease. and that the costs and benefits will continue to be incurred. But that's a different issue, because we're basically talking about the first 2 years post-surgery. Of course, eventually, after 3 years or more, those will go and fall into the population, which is just like the people who didn't go undergo bariatric surgery, statistically speaking. So that's about gallstones on their own, and gallstones following bariatric surgery. So is it worthy? I mean, is concomitant cholecystectomy necessary for asymptomatic cholelithiasis with sleeve? Is it necessary, really? So that's a study from Turkey, and they included 312 laparoscopic sleeve gastrectomies between 2012 and 2016. 24 patients were flagged to have asymptomatic cholelithiasis, and they didn't perform cholecystectomy for them. And they followed them up to 58 months with a mean of 27 months. They found that the risk of becoming symptomatic for asymptomatic gallstones is very close to the healthy population after sleeve gastrectomy, and that they suggested only observation for asymptomatic gallbladder stones in patients who will undergo sleeve gastrectomy based on their findings. So the incidence is very close to the normal. It is not necessary to do the cholecystectomy. The development of the disease up to 2 years is very well like the normal population, and that even can be enhanced with using the ursodeoxycholic acid to prevent the development of stones following bariatric surgery. And this is a study from Egypt where it is prospective controlled study with all the benefits of prospective studies. That included more than 300 patients who were scheduled for sleeve gastrectomy and randomized to receive 500 milligrams of EDCA for a month versus the group who took nothing. And they had ultrasonography done at 6 and 12 months after surgery, and they found that it was really, really effective. It reduced the frequency of stones from 7% for the control group to 2.3%. That will add further to the positive side of not performing anything with the procedure compared to what I'm going to show you now, the other face of the story. So this is a systemic review. So now we established that there is not a significant increase of gallstone problems if you don't do concomitant lap chole, and you can even improve on that with medication. So what about cholecystectomy in patients submitted to bariatric surgery? This is a systemic review and meta-analysis of cholecystectomy risks in bariatric patients. And they found that the incidence of gallstones following bariatric surgery is 0.34 per 1,000 population. That's well below the average, the international average for this study. And they found that the patients submitted to bariatric surgery alone had low incidence rate of bariatric complications, 5.5 per 1,000 population, a very decent percentage. The problem with adding cholecystectomy for patients with bariatric surgery, and as bariatric surgeons you know that, it increases the mean operative time up to 32 minutes, and it increases the risk of post-op complications, as I'll show you further. Again, that's another paper about elective cholecystectomy during Roux gastric bypass. And here, again, more than 300 patients who had concomitant cholecystectomy with gastric bypass. They found that the same findings from the previous study, combining these procedures significantly increases the operative time and the hospital stay by a significant, almost 1 hour and 2 days. And I'm sure that your CEO here wouldn't like having a patient staying for 2 days more than the standard. She's not here anyway, right? So, additional to that, the patient who underwent additional cholecystectomy had more overall complications than the rest of the cohort, and I'll talk about that further. So, this is a different study. It's a narrative review of the main database, a big database actually of PubMed and all those what you see there, and it was all about management of biliary stones in bariatric surgery, and it found that cholecystectomy concomitant with bariatric surgery is more challenging, and for the obvious reasons. Anybody who did a bariatric procedure for high BMI will appreciate that the trocars, the standard placement is not really as good as it is for the average bariatric patient on the high BMI, because the high visceral obesity, the increased operation time, and the large liver. And the thing is, when you do lap chole, you're putting your trocars on the right side of the body. When you do bariatric surgery, you're doing the central, and you're going at an angle with the big liver and a fully loaded calloid triangle with fat. And you're going from an awkward angle. I mean, adding more trocars will add more time, add more complications. So it is definitely something to ponder. They also found that in patients without signs, symptoms, or gallstones before bariatric surgery, the incidence overall biliary complications following surgery is, I talked about that. So their conclusion was that simultaneous bariatric surgery and cholecystectomy should not be indicated for all morbidly obese patients. Of course, our discussion here is about routine cholecystectomy, or in isolated cases, probably there might be some advantages in certain cases with low BMI, relatively low BMI. The thing is that this is even more serious with patients who are at high risk when with prolonged operation time. So, like those with hypertension, diabetes, and microcirculation disorders, amongst others. So, those who are subjected to higher complications or more time, we just showed data that shows that the least average time was 32 minutes, and other papers gave an increased time of 50 minutes. So those patients are definitely high-risk patients and should not be operated, have concomitant lap chole. And you can always go back and operate on this patient later, and all those negative things that I mentioned now are positive. Now you have optimal trocar, you have a reduced amount of visceral fat and reasonable operation time and much less liver steatosis, which will add to the safety of the procedure. What about the morbidity of the procedure with gastric bypass in a national database from Sweden? This is a big study where they had like almost more than 110,000 patients from 2007 and 2013, and they found statistically significant higher chances of postoperative complications in the concomitant cholecystectomy group, and their conclusions was that cholecystectomy should not be done along Roux and gastric bypass at the same session. The same thing here, that's a study from Greece now, and systematic literature research for PubMed and Cochrane databases was concluded, and it included 30 studies. It's a pretty big study, and the data for more than 13,000 patients. And here, the problem is not now only with gallbladder complications. This study have proved that there is a higher rate of anastomotic leak and stricture in cases of concomitant cholecystectomy with gastric bypass compared to those patients who didn't have gallbladder. Last three slides, Mr. Chairman. Those are two rather old studies, but they show that there is a significantly higher rate of rhabdomyolysis and precipitation of the proteins in the kidneys, and long operation time in morbidly obese patients, which will further increase the dangers of doing cholecystectomy with bypass. This is a schematic presentation of what I talked about. So it's basically, again, about not doing routine lap chole. So after all that evidence that we presented, which is roughly, there's the risk of de novo post-bariatric symptomatic gallbladder disease is around 8%. The risk of becoming symptomatic is close to the healthy population after a gastric bypass. Conservative management of symptomatic or asymptomatic gallbladder disease after gastric bypass is safe and can be offered in every case. Low percentage of patients required further cholecystectomy after 1 year, 3.4%. Patients submitted to bariatric surgery alone and low incidence late ovarian complications. Statistically significant higher chances of postoperative complications with the concomitant surgery, both for the bypass itself and for the gallbladder. So considering those evidence, is it added benefit or added stress? Well, Hippocrates can say that, and I leave it to you. Thank you very much.
Thank you very much, Dr. Taha. That was very, very clear. Lots of evidence behind, and I think we should avoid concomitant surgery. Occasionally, you find patients with a BMI of 55 who's had lots of gallbladder trouble. Everyone's reluctant to operate. They need bariatric surgery. They come in and have a percutaneous drain put in. So you need to do the gallbladder either first or at the same time as Roux by gastric bypass or a sleeve. In such a situation, what would be your approach?
Well, actually, you brought the most extreme example for discussion, and I think you go where safety first is.
Yeah.
If that patient had really suffered that much of gallstones, he has drain or something, and with a BMI of 50 something, I would go and remove gallbladder firstly, rather than doing concomitant.
Thank you very much. Thank you. And then come back and do the bariatrics later. Yeah. Thank you. Any further time for one or two questions? We've got the expert here. Yes, Mr. Charu at the back. Yeah.
Thank you for the excellent lecture. Could you say what is your normal practice in patients with symptomatic gallstones? You mentioned about asymptomatic. Asymptomatic, fine, don't touch them. But in symptomatic patients who come for bariatric surgery, would you recommend taking the gallbladder out at the same time, or you go at a later stage?
Yeah, I mean, I showed the evidence. I mean, you generally get higher complication rate if you do them both. So just like the chairman just said now, if you believe that this patient's problem is mainly gallstones, then remove them first. And then you come back and do the bariatric surgery later. I mean, I've done quite a few concomitant, but that was like in a patient with a BMI of 37, and they were insisting, and I told them, I can't give no promises. I'll go in and see. If it's straightforward, nothing, I mean, no strings attached, it's straightforward, I will do it. If not, then I will not. I mean, out of the probably 12 patients I told so, I did only 2.
What would you do if you found symptomatic gallstones, you do a cholangiogram, you find bile duct stones? Would you continue with that and then do the bariatrics, or stop?
Well, that's a totally different story. I mean, that probably would have been a dilemma 20 years ago. Nowadays, we have expert gastroenterologists everywhere. So a CBD stone, my gastroenterologist will deal with it. Mostly it's a walk in the park. And then you can go back to the standard approach.
So the question is, for these patients, do you do your imaging MRI before, or do you not MRI them, or you don't look for bile ducts?
So you're talking about a totally different thing. Now we are talking about the management of gallstone disease, right? So with gallstone disease, whether a patient is morbidly obese or not, when they come with a complicated gallstone disease, they will be managed as such. So they will go into the program that we have to assess gallstone disease. And of course, we don't do MRI routinely, but we do probably MRCPs more frequently when we do an ultrasound, the dilated common bile duct, patients with a history. So you do an MRCP, it's there, and you take it from there.
So my question really, just to put you a little bit more, it is really, the question is, how sure are you going to be that they don't have bile duct stones before your bariatric operation?
Well, you go. It's mostly clinical diagnosis unless it's coincidental. So patients, when they come to you with whatever history they've come with, you follow the standard approach. So they have the presentation that leads you to suspecting a common bile duct stone. There you go there. If there's nothing like that, I don't think you do it routinely.
Thank you. I think the take-home message from Dr. Taha is do no harm, and there's no loss of pride sometimes in making the clinical judgment and bailing out.
Thank you very much.
Thank you. Thank you.